Hello, I'm Chris Cook, an interventional cardiologist from the Essex Cardiothoracic Centre in the UK. Apologies, I'm unable to join you in person for the Young Interventionalist section of Transcatheter Heart Valves Greece 2024. But here I've recorded for you a case of minimalist transfemoral TAVI with a balloon expandable valve, and I've intentionally provided extended teaching on vascular access and closure, which remain the most important skills to develop as a young TAVI operator. Okay, enough from me. I hope you enjoy the next 10 minutes and hope to see you in person next year.
And what we're trying to do is find the femoral head. So you see that's just there coming in at the bottom of your ultrasound image. And I'm just going more medial very slowly. And you can see that you've got the artery there in the longitudinal form. I know from the CT scan that this is a low bifurcation, but I'm just gently coming down to try and appreciate that. Sometimes it's a bit tricky, particularly in tortuous arteries, but you see there's a nice bifurcation there. Then go slightly higher up again, perhaps a fleck of calcium. And then what we can do is just rotate 90 degrees, and now we've brought that vessel into the short axis, and it looks like a nice anterior wall. So I'm just now going to keep my left hand nice and planted, and you can see it's approximately a centimetre deep there. So that means I'm going to come about a centimetre away from the probe in order to do a 45-degree entry point. So I'm just going to give some anaesthetic to the surface of the skin. So I can do that blindly, really. I'm not looking at the ultrasound. I'm just giving some anaesthetic to the patient there. And then what I want to do is keep, as I say, my hand nice and planted with the left side. And then what I'm going to do now is concentrate and get slightly more onto the artery itself. So now I am looking at the ultrasound, and I'm just bouncing around to make sure I get the right trajectory. And I want to see my needle tip, there we go, just on the vessel. So I'm going to go either side of this and give anaesthetic to the adventitia. You can see my needle tip. I'm sort of calibrated my movements now. And again, just small amounts around the vessel to get a nice anaesthetic effect. And again, keeping my hand nice and planted, I'm now going to come away with the anaesthetic. I now have my micropuncture needle. I'm going to go in through the same access site, really. And then what we're trying to do now is just to get that needle tip right on the top of the vessel. So you can see just there, we're coming in at 12 o'clock, and I'm happy there. So I'm going to pop through the artery. I keep my left hand still there. And then what I try and do is just wire directly like this, and there's no resistance. At that stage, I'll stop and we'll move on to screening. First, we can see where the needle entry point is. So you can see that's right on the top of the prosthesis, which I'm happy with. And then here comes the ProGlide. Now I tend to have a wet swab here so that it just makes it nice and lubricious. I'm going into the artery, and then at about this stage, I then transition to hold the device like a pen, and then go into so, and then my second operator will kindly pull back the wire. I still control the artery proximally, just to make sure it doesn't prolapse at all. And you can see there's good flow. I don't go any further. I come to 10 o'clock. Number 1, lift the foot plate. I then go slightly vertical. 2, fire the suture. 3, harvest, cut. And then you must remember stage 4, which is to drop. I then come out, and then I push in slightly, and that brings both the sutures towards me. My practice is then to slightly pre-tighten. Thank you. And then I'll just go back to control this. We'll bring it out to the white marker, and then we'll rewire. So what I'm wanting to do is just put this at the base of the non, which I think is there. And then we're going to do an injection. Are you ready, Rajesh? Thank you. So this is Edwards up. This is the new sheath. I tend to go into the artery just to plug any bleeding. And then what we do is find the ring and just slowly going up. We'll try and go either side of where, so that's into the non. And I'm just rotating this catheter and progressively seeing if I can get into the left cusp as well. Sometimes a bit tricky in these tortuous cases, and also where there is horizontal. So I can put the catheter into what I think is going to lead me onto that left side, and perhaps as I come back it may cross. So I'm just making small movements, starting as I go, trying to time it with the heartbeat somewhat. So I can go on either side there. So I think it's somewhere in this region. And it was across there. There you go. So it's across. So I've just stopped everything. And you can see that the wire is now across the valve. What I then do is fix this wire. And I bring the catheter over it. I don't want it to go too far into the LV, but I want to have enough support. I come back with the wire. And now I'm just going to prolapse this catheter down to the apex, like so. Thank you very much. In goes the safari wire with the introducer. And this is sort of push me, pull me technique. So as the wire goes in, you see the catheter just taking an even nicer shape with the tip facing away. And I'm going to push on the wire as I come out of the catheter like so. And I fix the wire now, and I'm just walking back the catheter. I keep an eye on pacing just to make sure that I haven't caused any high degree block at this stage, which I haven't. And so now I'm just going to walk out this catheter. It's exactly as I'd anticipate it in a horizontal anatomy. And we'll just bring this valve around the arch to a vertical portion. Okay, so next we're going to bring the balloon into the actual valve itself. So the way to do this is we unlock, and then I just bring this in like so until the white marker is shown on the delivery system. I relock. And then now what I'm doing is, you can see on the screen, is bringing this balloon in. Now what I'm going to ask my radiographer to do now is to go more cranial, please, with the image intensifier. And what we're trying to do is square off the top of the valve. Very good, you can stop there, thank you. And I'm just going to bring it in, maybe 1 or 2 more millimeters. Okay, so we're going to bring this around the arch. Excellent. And then now we're going to get ourselves in position to cross the valve and then ultimately deploy it. So if we can just sort out our view, if we can see more of the left ventricle, please. We're less concerned about around the arch now, Tony. So what I'm going to do is going to cross, and I'm going to keep some of this flex on as I go because of the bicuspid nature. And just push that wire on a touch more for me, Rajesh, thank you. So here we go. We're going to cross this valve now. The nose cone is already across, like so. And then I'm going to bring back the pusher now. So if you drop the magnification, what you'll see is as I pull this back, you'll see that the pusher there is coming back, and I tend to bring that like so, and then I relock. That's very good. And then, Rajesh, if you won't mind just testing for me. Excellent. Okay, so we can mag to 22. It's a little deep for my liking. So the first thing is just to make sure the wire is truly at the apex, which it is. And then I tend to use this fine adjustment wheel. So I'm going to rotate this fine adjustment wheel, and you can see it's actually bringing that valve up in a controlled way. So a little test for me. That looks quite good to me there, Rajesh. Make sure my pigtail is indeed at the apex. And you can see because of the tension in the system, the actual pusher has come forward. So it's really important to always double check that. So I'm going to unlock, and I'm actually going to bring that pusher slightly back again. It can always catch you out slightly. And again, a little test for me, Rajesh. It looks very favourable to me, actually. Okay, so what we're going to do is clear communication here. So we'll have rapid pacing on, 180 beats per minute. Pacing on, please. 180 coming in now. And take an image. That's good, Rajesh. You can start inflating there for me, please. So it's a nice and slow inflation. That's very good. Keep going for me, Rajesh. I'll bring the pigtail back and commit to the... Thank you very much. Save image. And pacing off, please. And Rajesh is back on the wire. And what I do is I just bring the balloon out, taking off the flex as I come. Looks like it's gone in nice and coaxial. And so we've got a mean gradient there of 5 or so. So that's very satisfactory echo-based result on the table. Thank you, Joel. It's a very nice result, I agree. So we've got a nice coaxial deployment. Things to look at immediately at this stage is, firstly, to look for coronary filling. So I can clearly see that on the left-hand side and also on the right. I can't see any significant aortic regurgitation or paravalvular leak that needs any clinical input here. So from my point of view, this is a very satisfactory result from valve deployment. Okay, Rajesh, so I'm going to introduce this, and it's a sort of, again, push me, pull me, out I come, keeping the wire in as I exit the vessel with the sheath, like so. Thank you. Make sure the wire position is stable. And then you're always working on the longer of the two. And I tend to clip on here so that I don't get too confused. Quite superficial arteries, these. So not a huge amount of travel on that first one. That's to be expected. And then now we switch over to this side. Again, I clip that there to not get confused. Wind this around my finger like so. On with the ProGlide and try and get that suture down onto the artery. Good. So as you can see, we've got good flow. There's no obvious bleeding, and you're also looking out for any dissections, but this is very reassuring indeed.
I think Dr. Cook is not available for discussion. Any comments from the panel or the audience? Thank you very much. Hope you enjoyed these ABCs on the Young Interventional session.